I'm Murli Mohan, and I want to welcome you all to this webinar on interstitial lung disease. It's odd. One of my colleagues, when he saw this, commented this is like playing a test match during a T20 season, which was a clever comment. But I think we're all, who are cricket aficionados, like test matches as much as we like T20s. So let's hope we have as good, as rigorous a session as a test match does in this COVID season of T20s. We have an excellent panel today. We will be starting off with a short discussion, a 20-minute discussion on what's new in interstitial lung disease. Then we'll go on to 3 case presentations, and we'll be then going on to how one manages ILD in the season of COVID. And last of all, we'll be ending with a panel discussion. And during the case presentation of the 3 cases of ILD, we'll be having discussions after they complete the case presentations. So as I said, we have an illustrious panel here. We have 3 cases presented by Dr. Lakshmi Narayan from Mysore, and I'll be introducing him when he's presenting his case. Dr. Sunil from CMI Aster, and my colleague, Dr. Syed Tawshid. The expert panel will consist of Dr. Vimal Raj, a very distinguished radiologist who's transformed how we look at ILD at Narayan Hridayalaya and has been contributing to ILD diagnoses across the country. I know he gets people sending him CTs for his opinion. Rounding off this is our very dear Dr. Sujit Rajan, consultant pulmonologist from Bombay Hospital, Mumbai. And he's one of the persons we all look up to, not only for his excellent presentations, he's one of the best speakers I've had the privilege of knowing, but also as he's a wonderful pulmonologist and a very, very good human being. And I think that this refers, the same adjective applies to everyone on this panel. So without any further ado, let us start. And I'll be kicking off things with the new update in ILD management. I hope to keep it to 20 minutes and no more. I may need some help with yes, no, I've got it going. Can you all see my screen? Yeah, it's okay, right. So I belong to Narayan Hridayalaya Hospital. I have a very nice team, and I'll show you their pictures at the end. We have a big multi-specialty hospital along with a cardiac center. And we, in our multi-specialty hospital, deal with these interstitial lung diseases. I assume this is a group mainly of pulmonologists. You don't need a description of what is interstitial lung disease, except to tell you that, there are variable degrees of inflammation and fibrosis in these patients. And they have fairly similar manifestations, which makes teasing out which kind of ILD it is a little more difficult. Practically all ILDs at the end have fibrosis. And it starts with inflammation in most cases, except for idiopathic pulmonary fibrosis, where we don't see the inflammatory part of it very strongly. Goes on to fibroblast proliferation, recruitment of fibrocytes, transition from the epithelium to the mesenchyme, so-called EMT, and ongoing damage. Normally, this results in healing and then resolution, but in some cases, there's failed resolution. The myofibroblast persists, there's an altered matricellular infiltrate, and ongoing damage, and this leads to fibrosis. I'm so sorry, I must stop at this point and tell you we have another very distinguished rheumatologist, non-pulmonologist, Dr. Dharmanand with us, and he'll be contributing very importantly to the discussion which involves cases as well as a subsequent discussion of systemic sclerosis. And I'll introduce Dr. Satish when he joins us. Going back to my presentation, when you have fibrosis, the kind of fibrosis and the distribution of the fibrosis varies according to what initiates it. So if you have a mild to moderate injury, you're going to get mild diffuse fibrosis. And all the alveoli are involved, as you can see in this cartoon on the left, and the histopathology on the right. Not very much fibrosis. But when you have severe injury, then you have much more dense fibrosis. And this is what it goes on to anyway in the long run if the disease process is not checked. And you can see both the dense fibrosis in the cartoon and the dense, what leads to honeycombing in the histopathological slide. But the way the inflammation occurs, the way the injury occurs is also important. So if you have inhalational injury, then obviously the distribution is to the center of the lobules, through the bronchi, and you get a center, airway-centered fibrosis, sparing more the periphery until late. Whereas if you have something which spreads through the blood, or we don't know how it spreads, for example, autoimmune injury, then you tend to see a more peripheral distribution, not an airway-centered distribution. It's more diffuse and it's very irregular. That's what you're seeing in the histopathology on the bottom right. But we need to be careful because patterns change over time, and this very young, good-looking, innocent-looking boy can transform into that. I'm sorry, I'm getting a call now. Right, so that's how patterns change over time. And we're all used to this classification of how you approach the diffuse parenchymal lung diseases. And I prefer this one. And I prefer this one, which came out a few years ago, which talks about genetic predisposition on the left. And at the bottom, you have inflammation and fibrosis. And from left to right, the inflammation gradually comes down while the fibrosis keeps increasing. And I particularly like this because you can see that any pattern, organizing pneumonia, NSIP, UIP, can all result from all these etiologies. The autoimmune disease, drugs and dust, granulomatous, and can all be idiopathic. On the left extreme, you have cryptogenic organizing pneumonia, which is almost pure inflammation, though it's called organizing, and responds beautifully to immunosuppressive therapy if it's caught early, before extensive fibrosis sets in. At the bottom right, you have almost pure fibrosis with little or no inflammation. And the inflammation may respond to immunosuppressive therapy, while fibrosis, you better start antifibrotics. And that's really going to be my focus of the talk today. But we must remember that IPF is just one of the progressive fibrosing ILDs. And if you see this Venn diagram, you can see that IPF is at the center. There's a lot of conditions that overlap with it, from HP, sarcoid, drug-induced conditions, unclassifiable conditions, which is something we talk about more and more these days, CTD ILD, where there is a frank connective tissue disorder, which is where Dr. Dharmanand will come in, or one of the idiopathic pneumonias, the interstitial pneumonias with an autoimmune flavor. So we can't definitely say it belongs to one of the CTDs, but there is an autoimmune flavor to it. And of course, you have the idiopathic NSIP, which has some degree of response to steroids. And why do I come with this? I come because we say, how do we manage ILDs? And that's the most important question after you've made a diagnosis of ILDs. And again, as I said, you go back to this question of, are you dealing with something which is more inflammation or something which is more fibrosis? But the exact diagnosis is very important. This was a paper from the 80s. The lead author was the Margaret Turner Warwick, who's one of the doyens of this profession, has contributed a lot, and people still speak of her with awe. And she had this paper on cryptogenic fibrosing alveolitis, showing that if you use prednisolone, and even better if you use prednisolone and cyclophosphamide, you had better outcomes, better survivals than what was traditionally expected for CFA. But then the Panther IPF trial came along after we'd been using this triple combination of prednisolone, azathioprine, and NAC for many, many years. And to our shock and horror, we saw worse results with the combination therapy compared to placebo. The time to death and the time to death and hospitalization, the probability of going into hospital or dying was much higher with the combination therapy. And it started very soon. You can see by 15 weeks, there's already a big separation, the placebo arm and the combination therapy arm. So not only does the pattern matter, the etiology also matters. So here you have different patients with the UIP pattern, some who have a connective tissue disorder underlying it, and the other, the idiopathic interstitial pneumonia, the UIP pattern, which we would now call IPF. And you can see that the CTD ILDs, as we call them now, do much better than the idiopathic interstitial pneumonias. Again, whether you have an NSIP pattern or a UIP pattern, by and large, the NSIPs do better. But even there, if you separate them into the CTD NSIP and the idiopathic NSIP, you're seeing a very, very big difference in the survival. And we must also remember that not all NSIP responds to steroids. This is a fairly small study, but they followed people up very well. This is a Korean study published a few years ago in 2012. They looked at 35 patients, checked whether they were steroid responders or non-responders. And you can see that about 1/6 of patients were non-responders. All of them progressed. And at the end of 5 years, there were just 40%, 2 out of the 5 who were alive, 3 were dead. And you saw the steroid responders, most of them did well. They either improved or remained stable. 100% of them remained stable or actually improved. So you have a steroid responsive variety and a steroid non-responsive variety. And we can get a fairly clear idea of what these are if we make a diagnosis. And I won't bore you with it because all of you know which are the steroid responsive and the steroid non-responsive varieties. So to summarize, treatment for the steroid responsive ILDs is with either oral steroids, with or without an immunosuppressant like azathioprine, cyclophosphamide, or MMF, and increasingly we are using MMF, or with NAC. Again, that is a matter of question whether one should use NAC or not. So the main problem now is treatment for the steroid unresponsive ILDs. And these are predominantly IPF, but not necessarily IPF. And I think Dr. Syed is going to show you how our diagnosis of IPF is coming down all the time compared to when we were seeing them earlier before the 2011 update. And these are the progressive fibrosing ILDs, which are going to be the focus of my talk. And how do we deal with these? Fortunately, there's light at the end of the tunnel. So now the treatments that we have available for the progressing fibrosing ILDs are antifibrotic agents, and we have 2 of them, and many are in the pipeline. We don't know whether they'll work or not. But antifibrotic agents like pirfenidone and nintedanib certainly have been shown to improve outcomes really well. Patients who come in too late or patients who are unresponsive to the antifibrotic agents, and this is a small percentage, maybe about 10 to 20%, either have no response or respond poorly. They have the option of going on to lung transplant, which is now available in our country. And at all stages, one must remember you treat the symptoms to improve the quality of life, which is another way of saying early one institutes palliative care treatment. How do we know that a fibrotic condition is progressive? So we can look at the person's symptoms. Do they have worsening cough and dyspnea? What's happening to their quality of life? Are they having a general deterioration in the health-related quality of life? Are they specifically having a decrease in their exercise capacity? Are there more objective measures like the lung functions declining? The FVC comes down by at least 10% or the DLCO comes down. Are we able to map these changes on an HRCT where we are seeing the radiological abnormalities are worsening? Fibrosis is increasing and you can actually do a fibrosis score and you can approximately calculate the volume of the lung. And most importantly, is the patient having acute exacerbations which suddenly disturb the quality of life and can even be fatal? And we put everything together and get a global impression. Does the physician or the patient have the impression that the disease has worsened? So we use all these measures to decide if a person is progressing. But for research purposes, one usually focuses on the PFTs and looks at a decline in FVC and DLCO. We had some good news with the oldest recognized idiopathic pulmonary fibrosis, and we found that pirfenidone works. We've had good trials, the ASCEND Capacity 1 and Capacity 2, which told us that these work, with a significant reduction in the rate of decline of the FVC or death. We had a 48% relative reduction, and the difference between the placebo-treated arm and the pirfenidone-treated arm, fairly good study, 600 odd people. There was a difference of 148 ml in the lung function at the end of the study, and that's a sizable amount. 148 ml is more than the minimal, significantly more than the minimal clinically important difference. Of course, there is always a price to pay for these, and the person had many adverse events, nausea and a rash being the most common, but also other GI complaints, predominantly upper GI symptoms. But that was IPF. How does it work in fibrosing ILDs, which are generally grouped together as the unclassified fibrosing ILDs? And these could be fibrosing NSIP, chronic HP, or any of the other fibrosing ILDs. So there was a study reported at the end of last year, around about September. We had the initial paper, and in February this year, we had the paper in the Lancet Respiratory Medicine by Toby Maher and group, again a very distinguished panel. Double-blind randomized control trial comparing pirfenidone with placebo, 70 centers throughout Europe, 253 eligible patients. How did they say they were eligible to be called progressive fibrosing unclassified ILDs? So these were not necessarily IPF, but they couldn't also definitely rule out IPF. These had a percentage predicted FVC of 45% or greater, very similar to the inbuilt study that I'm going to talk about later. They had a DLCO of 30% or higher, so they were not very far advanced, but pretty far advanced in the disease. And they had more than 10% fibrosis on the HRCT. And what were the results? The FVC declined by more than 5%, was definitely reduced to the pirfenidone group. The odds ratio was 0.42. A greater than 10% decline compared to placebo, the odds ratio was just 44%, 0.44. The DLCO came down by about 7% as compared to the, 0.7% as compared to the placebo, where it had declined by 2.5%. In this study, they looked at both home spirometry, which strangely was the primary endpoint, but they also did on-site spirometry. And unfortunately, there was a lot of variability. I have not put the standard deviations here, but there was a lot of variability, which is why it did not meet the primary endpoint, which I think was a bit ambitious, the home spirometry. But even there, you saw the mean spirometry decline in FVC was minus 87, dropped by 87, whereas placebo dropped by 157. That's a difference of, correct me if I'm wrong, about 70 ml. In the site spirometry, there was a difference, on the other hand, of 95 ml, which was highly significant. The 6-minute walk distance was a difference of about 24 meters, which was also quite impressive. How did nintedanib do? Nintedanib, we know, has multiple points of action, as this slide shows you. I'm not going to take you into details, but it works at almost every point where fibrosis kicks in. And this is because nintedanib is a triple kinase inhibitor. It doesn't work at only one point. It works at multiple points, through working through multiple targets. And nintedanib is also equally effective in IPF. And strangely, the improvement or the lack of decline in the Impulses trials and in the earlier Capacity and Ascent trials was almost the same. You saw that there was a 125 ml difference in Impulses 1, 93 ml difference in Impulses 2, and these were done at the same time. So very impressive improvements in the rate of decline of FVC. There was also an improved, this is the overall, when you combine the Tomorrow and Impulses trials, about 111 ml. So this consistency we saw across all the antifibrotic trials. And the thing that we saw with nintedanib, which was not reported initially in the pirfenidone trials, was it postponed the first exacerbation. The time to the first exacerbation was much later in the nintedanib arm as compared to the pirfenidone arm. I'm sorry, to the nintedanib arm. Does it work in Asians? This was an Asian subgroup analysis which came out late last year and showed that we got the same kind of benefits, 94 ml in the Impulses trial, and in the continuation phase where people continued nintedanib if they were on nintedanib earlier, or they were initiated on nintedanib if they were on placebo earlier. They did equally well, 126 ml in both groups, and this was because they did not want to deny the benefits of nintedanib to those who were on the placebo arm earlier. So the Asian groups do just as well as the global groups. But the big question was, will nintedanib, being an anti-fibrotic, work in all fibrotic and ILDs? And this is why the INBUILD study was started. Again, a double-blind randomized controlled trial of progressive fibrotic ILDs. Similar criteria, more than 10% volume being involved on HRCT by fibrosis. Nintedanib was given at a dose of 150 mg twice daily, just like in the INPULSIS trials. And these patients were followed up for 24 months. 314 in the pirfenidone group, and almost the same number in the nintedanib group, and almost the same number in the placebo group completed the 52-week trial, telling you that side effects were not a significant problem. And what did we see? We saw a very similar pattern, 128 ml difference between the amount the placebo group declined as compared to how much the nintedanib group declined, just like we saw in the INPULSIS trials. What does this suggest? This suggests that nintedanib works equally well for the fibrosing ILDs which are not classified, just like it works for the better classified IPF. Going on to a special group of fibrotic ILDs, this is systemic sclerosis. And in systemic sclerosis, the ILD outcomes are very, very confusing. So this paper looked at people who survived, followed them up, and it showed that in some of them, the disease seemed to burn out and they did not progress. And about 37, the majority of them, survived for more than 8 years, or the largest group, I should say, not the majority. About 19, half that number survived between 4 and 8 years. But there were some, 25 of them, who survived for less than 4 years. They progressed, in fact, much more rapidly than what one expects for the other fibrotic ILDs. And this is confusing because there have been other papers which said that systemic sclerosis-associated ILD does actually better than the non-systemic sclerosis CTD ILDs. And we are seeing this kind of discrepancy very often. But there seem to be various confounders, because if you break these down, it looks like those with limited cutaneous varieties of systemic sclerosis do much better than those with the diffuse cutaneous varieties. And the best variety is probably those who are sign scleroderma systemic sclerosis. Again, if you break down the systemic sclerosis into those with, compare them with those who have associated CPFE, obviously people with CPFE associated with systemic sclerosis associated ILD do worst of all. It may also refer to the kind of antibodies that you isolate, and those with the RNP do better than those who have the anti-topoimerase antibodies, and the anti-centromere and the anti-RNA seem to do something in between. So you can predict who's going to do well and do badly. Obviously, if a person has associated pulmonary hypertension, they do worst of all. And those with ILD alone, without pulmonary hypertension, do best of all. So you really need to tease out in SSC ILD what kind of patient you're dealing with, what does it look like clinically, what does it look like antibody-wise, and is there any associated interstitial lung disease? Then you'll get a better idea of how to prognosticate these patients. And in this group, they did a census trial of nintedanib versus placebo. Again, a very, very similar trial design, so I'm not going to go into it. But again, here you're seeing that there's a very big difference between those who received nintedanib. They did much better, a difference of 41 ml as compared to those who received placebo. And interestingly, in the placebo group, you had a decline of 93 ml per year. In the nintedanib group, you had about 52 ml a year. And this is better actually than those we've seen with the IPF varieties, where the decline in the placebo group was much higher. So maybe systemic sclerosis ILD does actually better, but we must remember that this is a homogeneous group. The other interesting thing was the Rodnan skin score didn't change. There was no difference between the trial and the control group. And this suggests that nintedanib does not work equally well in all areas of fibrosis. And the St. George Respiratory Questionnaire also did not show a significant difference. So the last part of my talk, how does one approach a fibrosing ILD? This is a paper by Vincent Cotin, whom you all know is one of the leaders in the field of ILD. He says you start with a comprehensive evaluation. Then you can try and come to a working diagnosis or a very definite diagnosis, or even after a multidisciplinary discussion, you may still end up calling it an unclassifiable ILD if you're fairly strict about how you apply these criteria. Now you have two choices. You can either treat them straight away or you can wait and watch. If you wait and watch, you monitor disease progression very carefully using the clinical assessment, serial pulmonary functions, and follow-up HRCTs like mentioned. If they are progressing, you decide to treat, and then you continue to monitor progression. You also look at the disease behavior in other aspects other than just lung disease. And then you can say those who don't have disease progression, you could just wait and follow up. Or the ones who are progressing now meet the criterion for calling it a progressive fibrosing ILD, and you can decide to treat. So to summarize your treatment choices, if you have IPF, antifibrotics are the first choice. If you have CTD-ILD, immunosuppressants like prednisolone, azathioprine, and MMF are the first choice. And with chronic HP, you can remove the offending agent, but these patients have often gone into an irreversible stage of fibrosis. So you can introduce steroids along with the offending agent or other immunomodulators, and you can give them rituximab. But at all stages, if a person is fibrotic, you must consider antifibrotic agents. And at all stages, you must consider best supportive care or palliative care. So this needs to be introduced fairly early. So I'll leave you with a few take-home messages. The fibrosing ILDs are a group of ILDs which are characterized by progressive fibrosis. The markers of progression include worsening on any or all of these features, clinical features, the exercise tolerance. Typically, you look at the 6-minute walk distance. You look at physiological parameters like FVC and the LCO. You can look at imaging and calculate how much the fibrosis is worsening. And you can look at a physician, a patient, or a global score. And finally, antifibrotic agents, especially nintedanib, because we have a better meeting of the endpoint for nintedanib. The fibrotic secondary endpoints were also met with in the phenidone group. So antifibrotic agents may be useful in all fibrotic ILDs, including systemic sclerosis ILD. And I'd like to stop by thanking our multidisciplinary ILD team. We have a big team, as you can see. And on the left, we have our radiologists led by Dr. Vimal. And on the right, we have physicians who offer us excellent support. And some people who couldn't make it to this photograph and who've undergone changes in their appearance after COVID crisis started with removal of the beard. So I'll hand you over now to our group who are going to take us through the cases. Please keep your questions coming, and we'll answer them during the end of the session, during the panel discussion. So our first speaker today is Dr. Lakshmi Narayan. Dr. Lakshmi Narayan is a pulmonologist from Mysuru, one of the leading pulmonologists there. He's got wide expertise in treating a whole range of pulmonary disorders, airway disorders, of course, TB, interstitial lung diseases. And he's also vastly experienced in the field of interventional pulmonology and sleep apnea. So I'll hand over to Dr. Lakshmi Narayan for the first case.
I hope I'm audible to all of the participants. Can everyone hear me? Okay, so I'll start with my presentation. So, yeah, I've put the slideshow now.
Yeah, Dr. Narayan, please go ahead.
Yes. So, this is a case which I saw about a year and a half almost ago. She was a 56-year-old lady, a homemaker. She presented to me in January 2019 with progressive breathlessness and dry cough for about 6 months. And she said she had rapidly worsening breathlessness for about a couple of weeks before she came to me. She did have several small and large joint pains for more than about 10 years, but there were no deformities. And she had recent onset weakness and fatigue. along with pedal edema. She had history of alopecia, but there were no skin lesions, and there was no history to suggest any infection when she presented to us. And as is routine in most ILDs, we went through the checklist. There was no exposure to any pets or birds, no exposure to organic or inorganic dust, no bias exposure. She was hypertensive, no diabetic, no past history of TB, and she was diagnosed as a connective tissue disease. And however, someone had labeled her as rheumatoid arthritis, some had labeled her as undifferentiated CTD. And initially, she had history of methotrexate intake several almost 10 years back, and since then she was on mycophenolate about 500 milligrams twice a day, and she was under irregular rheumatology follow-up. And on examination, she was cyanosed, and there was bilateral fatigue pedal edema, no clubbing. There was joint tenderness in both small and large joints, no rash, no muscle weakness. She was hypoxic on room air, and she had tachycardia, slightly tachypneic. Respiratory system, there was extensive end inspiratory microfractals at the bases, and there was some evidence of airway involvement in the form of polyphonic wheeze, especially expiratory. And there was clinical evidence of pulmonary hypertension in the form of loud P2, elevated JVP, and the systolic. The investigations, we admitted her, and the evaluation and treatment is when she came, she was quite breathless. And the basic investigations like complete blood count, liver and renal function test were normal. ESR was slightly elevated, CRP not so much. The creatinine phosphokinase was normal. The ANA was strongly positive, and so was the rheumatoid factor. However, anti-CCP was negative. And the ANA immunoblot turned up two antibodies positive, anti-Jo1 and anti-Rho52. And she had a severe restriction, both FEV1 and FVC were less than 1 liter. In 6-minute walk test, she desaturated to about 80% and could only walk about 190 meters. And echo revealed severe pulmonary hypertension. This was her chest imaging, and the radiograph showed extensive bilateral ventricular capacities, but with fairly preserved lung volumes, which can be observed. And this was her CT scan of the chest. There was a definite epicobasal gradient of disease, and the upper lobes were fairly spared, but there was a lower lobe and basal predominant honeycombing. And the honeycombing, as you can see, was quite florid, giving rise to these cystic changes, a lot of irregular cystic opacities. And our radiologist reported it as bilateral reticular opacities with traction bronchiectasis and honeycombing. And the honeycombing, he remarked, was quite extensive, and it was florid with several cystic areas, favoring a UIP pattern. And the opinion was that this kind of florid honeycombing is more likely to be connective tissue disease related, especially given the background of history of joint pain and the autoantibodies being positive. And compared to there were old CT films, which unfortunately I couldn't present now. And compared to the CT films dated about 2.5, 3 years prior, there was significant interval progression of disease of the honeycombing. So she was not fitting into one particular connective tissue disease. So we labeled her as an undifferentiated connective tissue disease with interstitial lung disease, probably UIP pattern, and core pulmonary hypertension secondary to both the ILD and the connective tissue disease. And given the progression over the last 2.5 years and the recent worsening of breathlessness over a couple of weeks, we discussed with the rheumatologist and decided to proceed with a higher immunosuppression. And she received 3 pulses of methylprednisolone. She was quite hypoxic and breathless on admission. And also, we decided to give her rituximab, 2 doses of 500 mg 2 weeks apart, along with other supportive treatment for core pulmonary. And she did show encouraging signs of improvement pre and post treatment. there was a relatively rapid improvement in her oxygen saturation, FEV1, FCC, the 6-minute walk distance, and her MMRC dyspnea also decreased. Symptomatically, she started feeling much better. She was discharged in about 5-6 days, and she required home oxygen for a few weeks. And we got an X-ray done about 4 weeks later, and there was some improvement. As you can see, there is some reduction in the reticulonodular opacities. However, given the degree of fibrosis in the CT, we did not expect much improvement radiologically. About 6 weeks after rituximab, she developed high-grade fever, cough, and purulent sputum, and there was new onset consolidation with positive markers for infection, and the CD20 count was almost zero because of the rituximab, and she was treated with IV antibiotics, required a week of admission. The steroids were naturally tapered further after the infection, and this was the patch of consolidation which she developed about 6 weeks later. And with antibiotics, that did show improvement. All this while, you can see how the lung volumes were remarkably preserved, this patient. And we continued her on maintenance low-dose steroids. She developed recurrent chest infections. 3 admissions she had required, including the one which I described. After 6 months, however, she has been stable. And we decided to restart mycophenolate in consultation with the rheumatologist. She's tolerating about 1,000 milligrams per day, unable to go beyond that. And since the last 3 or 4 months, she has been stable. The saturation, the 6-minute walk distance, the lung functions, they've all remained stable. And we did consider antifibrotics in this patient. And I would like to pose the questions to the panelists. And seeing Dr. Mulimo's presentation and the data of the census trial, I do believe that this patient may have a role for nintedanib in such patient. And of course, there are questions whether to try nintedanib upfront or whether to go for immunosuppression and then add on, and whether to try them both together. So these are the questions I believe it's open to the panelists. I would like to take their opinion.
Have you finished, Dr. Lakshmi?
Yes, I finished.
Okay. So, can I request, Dr. Dharmanand and, in fact, all the panelists,
yes,
but we'll start with Dr. Vimal. Yes. Dr. Lakshmi Narasimhan, can you show us the CTs again? And I'll ask Dr. Vimal to comment on these.
Thank you very much. I think this is a wonderful case in the sense that the chest radiograph that we could see earlier, one of the things that was very apparent even at that time was that the pulmonary arteries are quite dilated centrally. So one would imagine in terms of the underlying pulmonary hypertension. And as you said, the lung volumes are relatively well preserved. And as we go into the CT, 2-3 things which are very interesting, and we discuss this in our ILD a lot. When you see at this top level of the lungs, the subpleural disease that we are seeing, and on the left bottom image, you kind of see a layer of subpleural line, like a linear atelectasis that we can see as a second edge of the lung that we are seeing. Exactly. That is something which is very classically seen in connective tissue diseases. That's something which we see in CTD-associated ILDs. And a lot of the cases, this kind of becomes a clincher. And as we go towards the lung base, the cystic changes are there, significant, which is quite right, as your colleague has pointed out, that there is significant honeycombing. But then there are also areas of actual subpleural secondary pulmonary lobule which are not cysts. They've just become emphysematous. They've just become overinflated, especially if you start seeing in the left lower lobe along the lateral aspect. Those are not become fully cystic in there, but this is clearly with some interspits areas of ground glass. And what you can see at the top slices and the rightmost bottom, the esophagus is slightly dilated. I don't know if that is just in this image or whether we may be seeing it in many other images also, but it fits with a fibrotic interstitial lung disease. Would like to call it as one of the intermediate classifications, where this is CTD ILD. I wouldn't have gone to call it a UIP just because of the ground glass and kind of some areas of sparing in the subpleural aspect. But this would fit in with a CTD associated ILD.
Right. Vimal, I wanted to ask you, does that explain why the volumes are preserved? Because as Dr. Lakshmanarayanan is pointing out, throughout the volumes have been beautifully preserved.
So the hyperinflation, which I say is one of the main reasons that the volumes are really well preserved. And of course, although we are saying the cystic changes, but they are not actual areas of classical honeycombing where you get a lot of fibrosis with more of traction dilatation. So here there is a lot of hyperinflation, especially towards the periphery of the lungs. That is the reason that the lung volumes are relatively well preserved.
And, we keep talking about Jonathan Chung's criteria to tell us that it's more likely to be a CTD-ILD. Do you see any of that exuberant honeycombing here, or?
Exuberant honeycombing, I would say there are focal areas of significant honeycombing, but it does not reach up to the literature of exuberant honeycombing. And also when they talk about the straight edge sign, the lung edge, it's difficult to say on these axial images, but the coronal images we should be able to see.
I saw the coronal images. There is no straight edge sign.
There is no straight edge sign.
And there is no anterior, the upper lobe, the anterior sign is also not present.
Okay, so that would be, I would agree with that as well, yes.
Is there an argument for, I'll tell you what, let's go on to Dr. Dharmanan. Dr. Dharmanan, this seems to be a patient with a connective tissue disorder. The rheumatoid factor was high, as well as the anti-Jo1 and the anti-Ro52, with the NA being 3+. How would you, see this patient, and how would you treat?
Yes, very fantastic case. Rheumatoid factor is very non-specific, which can occur in many connective tissue disease. So if the patient was anti-CCP also positive, then we would classify him as rheumatoid arthritis. And the 10 years of arthritis without developing any telltale deformity, without a specific treatment against rheumatoid arthritis is very unlikely. So rheumatoid factor is an epiphenomenon which can occur in almost all connective tissue disease. And clinically, unless we examine, we can never say, but doesn't seem to have any obvious dermatomyositis features in the clinical presentation, whatever he has mentioned. And there is a small mention about alopecia. I'm not sure whether it is alopecia areata or a diffuse alopecia to really comment on. And probably what went wrong here was if it is a connective tissue disease from last 10 years, we would have probably done a yearly PFTs and echocardiogram to look out for pulmonary hypertension and ILDs, and we could have picked it up at a much earlier stage. Probably the patient was not compliant with the rheumatologist. That's what I would assume.
Or may not even have seen a rheumatologist.
They have seen a rheumatologist.
They were not compliant with the.
Not compliant.
Yeah, the MMF was started years ago, and they just continued it without following it.
And the pulmonary hypertension here seemed to be secondary to ILD rather than predominantly pulmonary hypertension. And I'm not sure whether you would do a right heart catheterization in these patients to differentiate whether there is an element of primary pulmonary arterial hypertension. So probably this is, we can really give a proper name to this patient. So definitely it's a patient with undifferentiated connective tissue disease because has symptoms of arthritis and autoantibodies. So I would call it as undifferentiated connective tissue disease, or probably IPAF.
Dr. Syed, Dr. Sujit, anything you would like to add? And we'll leave the last word with Dr. Lakshmanarayanan.
Wanted to know from Lakshmi whether we had any further scans on this previous or new ones, Lakshmi, to compare with?
We had a scan, but it was about 6 months after the first scan. There was no difference. That's why
there was no difference.
There was no difference. It was the same.
Okay, so I think it would be then probably a bit premature to start an antifibrotic without progression on the scan, without clear lung function evidence of deterioration. I would probably wait a few more months before the antifibrotic, which was your question at the end, right?
Yes.
Right.
Dr. Murali, that this patient also is a typical patient of connective tissue disease, ILD, doing very well with the treatment. So if I have looked at the CT scan, I would not have probably thought about giving a full throttle and immunosuppression, because I thought probably a lot of more fibrotic changes, irreversible changes. That's what I would have thought of, and I would have discussed with the pulmonologist. And in this patient, the steroid seems to have helped her rather than rituximab, because steroid works faster.
Much faster.
Much faster. Whatever you see in 3 weeks, 4 weeks is due to steroid effect. If I were the rheumatologist, probably I would have suggested a course of steroid, increase the mycophenolate, rather than go to rituximab straight away.
I'd also be worried, if I may just comment, Lakshmi, with rituximab, and maybe Dr. Dharmanand can comment, the half-life is very long. And in a COVID pandemic, I would certainly not give it. Probably in another era, I'd be safe, because that's a long half-life with that drug.
I agree with you. Once it is gone, it is effective for at least for at least 3 to 6 months. 6 months
true.
minimum. Yes.
In hindsight,
That's what
even
it
this
showed
patient suffered several infective episodes, which I think were probably after the CD25 completely knocked off. She did suffer several infections. And it was probably the steroid which actually helped.
Yeah, and steroid probably rituximab would help, probably definitely help. But the initial response we have seen was with the steroids,
Yes.
and the steroid is the one which is more immunosuppressive than probably the biologicals and rituximab. At this dosage, that steroid is the cause for the infections rather than the rituximab. I would say definitely. Maybe if anything coming after 2 to 3 months, particularly CMV pneumonia, viral pneumonias, probably we could attribute to rituximab. But what you have had acute, what looked like a bacterial pneumonia, which recovered, I would attribute it to steroid rather than rituximab.
One question which I had for Dr. Dharman, if I may answer.
Yes.
Yeah. So the question I had was, you get several of these patients, they show kind of inflammatory changes in the joints and maybe some other organs. But in the lung, it's predominantly a fibrotic response. So that's a bit confusing sometimes, because the rheumatologist and the pulmonologist always have a discussion. The patient is having active skin lesions, the patient is having active synovitis, but in the lung, it's predominantly fibrotic. I'm sure you've seen many patients without much ground glassing per se on the CT, or without much inflammation in lung biopsy. But the inflammation is there in the other organs, obviously. It's kind of confusing, and whether to go with antifibrotics predominantly or with immunosuppression, or whether to give both together is a. So
Yeah,
how do you tackle?
Yeah. The choice of treatment depends upon the dominant symptoms. Say if the arthritis is really troubling the patient, and if their lung disease, assume that it's rheumatoid arthritis, lung is more fibrotic, and you don't think it is inflammation. But florid rheumatoid arthritis, which is crippling, I would still give them rituximab or a drug which is similar to that, and hope that has got some benefit for the lungs as well. So the choice of drug depends upon the dominant symptoms. So if ILD is a dominant symptom, like a rheumatoid arthritis with ILD dominant, cyclophosphamide will be the drug of choice rather than methotrexate there. So we try to look at what is active. Then active ongoing scleroderma or dermatomyositis would require treatment for that conditions, and probably you have to choose a lung safe drug. That's all. I would not choose anti-TNF if there is rheumatoid arthritis and ILD going on. I'll choose probably rituximab or tocilizumab rather than anti-TNF. So the choice of drug will depend upon the comorbidities and organ involvement.
And one final question for Dr. Murali. Dr. Murali, are you there?
Yes, I'm here.
Yeah. What about specific anti-pulmonary hypertension therapy in such patients?
So I think the decision is really made on whether you think it's the lung that is contributing, or this is a primary, what used to be called primary pulmonary hypertension, or now better called idiopathic or associated pulmonary artery hypertension. And you usually go by, is the patient hypoxic or not? Here the patient is hypoxic. So the treatment then would be use oxygen rather than one of these other drugs. Now remember that a patient can be hypoxic also because of pulmonary hypertension. So then you go by what the DLCO shows and the FVC shows. If the FVC is high, more than 60%, some people use a cutoff of 70%, and the DLCO is also high, better than 60%, then it's more likely to be the pulmonary artery hypertension, the group 1 hypertension, in which case it makes sense to use the pulmonary vasoactive drugs. On the other hand, if, as in this patient, you had a very low FVC, you have a low DLCO, the person is able to walk only 198 meters, the CT suggests that there is extensive disease, not only the interstitial fibrosis, but also emphysematous changes, then it's much more likely that it's hypoxia that's contributing. So using a pulmonary vasoactive medication may actually be counterproductive. So in such cases, I would use only oxygen.
Did the echo improve, sir?
Yeah, the echo improved. I forgot to put it. It's around the echo, the pressures are now around 45 to 50.
Okay,
so the echo did it. With oxygen, it did.
Yeah,
that's
ILD. Probably ILD must be the dominant feature.
Yeah. Then I wouldn't give a pH therapy at all.
Yeah, I would not suggest as well.
So can we move on to our next patient? We are running short of time now. Our next case is being presented by Dr. Sunil Kumar. He is the chief pulmonologist at Aster CMI Hospital, which incidentally also runs an ILD clinic. Dr. Sunil Kumar is an established clinician and researcher in pulmonology, critical care, and sleep medicine. And he's had extensive training, academic training, and professional experience in India, Germany, and the United States of America. He trained with one of our best interventional pulmonology teams, headed by Dr. Ravindra Mehta, and is doing a lot of very good work right now. I'll hand over to Dr. Sunil. I failed to introduce Dr. Dharmanand earlier, so if you just give me a second, I'm going to introduce Dr. Dharmanand too. He's the president of the Karnataka branch of the Indian Rheumatological Association since 2008. He's currently the secretary of the Indian Rheumatology Association, and he has, trained many more rheumatologists. He does organize a lot of our CMEs in Bangalore, and he is our go-to man. He's my go-to man, not only for my rheumatology cases, but also whenever we have a program like this, Dharmanand is the one I go to. Right, I'll hand over to Dr. Sunil at this point.
Am I audible, sir? Yeah. At the outset, I would like to thank for getting me an opportunity to present our work which has been done in our Aster ILD clinics. And I think after a wonderful presentation with Murli sir regarding the brief introduction of how the things of management of ILD has revolutionized in the last couple of decades, actually, which gives an immense amount of confidence to present these particular cases in this particular forum with such a learned people of being supporting in terms of how to get this maximum out of each and every what small things what we do in terms of getting a diagnosis. And we'll just to enumerate this concept of CTD-ILD, we'll run through one case actually, who is a 30-year-old female sales executive working as to run this, I think we have a 30-year-old female who is working as a sales executive at a Decathlon sports company actually from Bangalore. She presented with a cough, predominantly a non-productive cough from past 2 months, and also exhaustional breathlessness of level 1 from past 4 weeks. And when well into the past history, we were able to know that actually there's no any people diabetes or hypertension or any sort of an asthmatic tendency in the past, and significantly she had a reflux or gastroesophageal reflux disease which is contributing in the past. Apart from that, she also had a history of frequent travels, exposure to pigeons, and cement dust. Now, the history will not go to without getting into a comprehensive details of the history. And to our ILD clinic at Aster, we run through this sort of ACCP questionnaire, which will be taken meticulously in terms of dissecting the data of how the historical thing will generally go to matter in a case of an ILD when it comes to a questionnaire-based approach to any of the ILDs. And if you can see this, the chest foundation, which comes with a 20 points questionnaire, which will give us some sort of a comprehensive history to go for what are the possibilities which can be the contributing for this sort of ILD, what we're dwelling with actually. Now, when it comes to initial 4 to 5 points, we'll just dwell upon cough. Predominantly, this, I think probably Lakshmi also goes with my visit actually, where both of us started with Jan 2019, where our patient presented with cough actually for 3 months, and it was so disturbing that in the night time also was awake and also was not also any sort of a phlegm. When it comes to shortness of breath, from past 4 weeks, what sort of a shortness of breath is, whenever she was used to walk on a level ground at a hurried pace, she has this sort of a shortness of breath. And also other, what are the associated symptoms like heartburns, small finger joints in the joint pain, or skin rashes. At the same time, there was no any significant smoking history in the past, but father and a sister are an asthmatic history. Now, to cut this sort of a short, actually, now what is the sort of a house setup, what the patient was in the last 10 years also been taken into account in this particular questionnaire, where patient is held in a 20-year-old house and also a significant birds, pigeon exposure, where 2 to 3 months she was exposed in her apartment actually, and also was a water pipe leakage which was noted in our apartment also. These are two things which gives us some sort of a environmental history in terms of figure of this sort of a thing. And she was born and brought up in Sri Lanka from past 26, and from past 2 to 2.5 years she's been in Bangalore and working as an executive at a Decathlon as a sales executive. And also the history about your occupational stuff, where she was exposed to tremendous amount of cement and dust, and also there was cement factory around which is less than 2 kilometers from her working place. So this summarizes some young female who is coming with shortness of breath and also cough predominantly with some sort of environmental triggers, and also working in a place where a lot of dust and cement also contributing to this. With this history, we go to examination where no other ictus, clubbing, lymphadenopathy or pedal edema, febrile with heart rate of 88 per minute regular, and also blood pressure of 110 by 70 millimeters mercury. And when it comes to saturation, baseline room rate is 95%, and CVS examination is unremarkable, and respiratory shows bilateral basal crackles, and also abdomen soft, non-tender, no organomegaly, and CNS is also no neurological deficit noted at the general physical examination. This is an X-ray which shows that the lung volumes are quite preserved with a bilateral basal haziness, which is noted in this particular patient. And subsequently, as a part of a workup of somebody with this sort of a basal crackles with a young female with mild hypoxia, we generally went with the pulmonary function test, which shows that initially on baseline, we have this sort of a PFT on the left side. We can see that FEC of a 56%, FEV on a 57, points out the possibility of more of a moderate restriction pattern, what is noted on a PFT. And we did a DLC also. We showed a 48% of DLC with qualifying for a moderate amount of diffusion abnormality. And when it comes to 6-minute walk, she is much more preserved actually in terms of heart rate being stable. Saturation was 95, dropped only to 93%, and she was able to walk nearly 442 meters in the 6 minutes. Subsequently, we did a CT scan also with this particular patient. Actually, you can see that your left upper thing actually shows the upper lobes actually, and you can see that predominantly ground glass opacities with, I think, subtle subpleural sparing, which is noted in this particular CT scan films. And at the same time, there is one word of caution that your esophagus slightly dilated, which is noted in this particular patient. And as you go down, actually, it's a more of a apico-basal gradients in terms of ground glass opacities. And at the same time, if you give the mediastinal record, there have not been much of a significant mediastinal lymph nodes, except that patient has a sort of a apico-basal gradient with predominantly ground glass opacities, more so in the bilateral basal zones. And with this, a possibility of NSIP. And if you run through this particular video of CT scan images, you can see from the apex to the base, you can see that apical not much. As you go down, you can see that extensive ground glass opacities in volume with subtle subpleural sparing and predominantly bilateral basal involvement with mild amount of traction bronchitis noted in both the sides of the basal lungs. At this point of time, we went into the lab also to support whatever the things what we are dealing with. Actually, we see that CBC unremarkable except ESR, which is 48. Otherwise, most of the renal parameters and urine examination also quite normal. Pre-op serology also was negative. And echo, unremarkable with good LV function with PAC of 24 millimeters of mercury. Went in with a young female with this sort of a picture of an ILD in back of a mind, CTD workup, RF factors 12.9, and ANA shows a nuclear pattern of 2+. Then subsequently ANA profile was ordered actually. We showed positivity for SL70. Then with this thing actually, we had this sort of a provisional diagnosis of a lung dominant CTD with ACL70 associated ILD, and also a possibility of pigeon exposure and also a dust, which was a cement dust which was exposed at the workplace also. We thought probably hypersensitivity pneumonitis also could be one of the things. So we had this taken up this particular patient to our multidisciplinary discussion, and then we had a thorough discussion about what are the possibilities and how to go about. And we came up to the conclusion that we won't go for a cryo lung biopsy, new kid of the block actually, where cryo biopsy which is revolution, at least in terms of getting a good adequate amount of tissue, so that we can have a good histopathological representation in any sort of ILD where there's any ambiguity to go ahead actually. With this cryo biopsy, this is a 2.4 probe actually, and you use as a liquid nitrogen actually to get these samples done. Actually, this is the way how we go to choose. Actually, you can see that right upper quadrant, the X-ray of rigid barrel going in with the bronchoscope and the distal cryo probe which is noted. Now, when you go into the distal area of interest by following a CT scan, we're looking for two safety measures what has to be done. One, the distal end of the probe, you go with the under a fluoro guidance. At the same time, the risk of bleeding can be curtailed to some extent by using a Fogarty balloons, which comes as an insurance policy to curtail the risk of bleed. In the right lower part of the screen, you can see that the Fogarty balloon, which is nicely inflated, once we go to yank and pull the probe out from the desired site of the lungs. This is some sort of a picture actually we encounter when it comes to a cryo lung biopsy. These are the good chunk of tissue which I think probably any of the pathologists would like to go for this reporting this particular pieces, so that we have a good amount of tissue. At the same time, the most direct complication of one, bleeding, and second, the pneumothorax. Post, I think we make it a checklist that post cryo we go for this particular chest X-ray, and there was no any remnant of any sort of a pneumothorax in this particular scene. Now, as the patient got better and got discharged actually, then the progress report of what we have done in terms of bronchoscopy and the cryo biopsy comes up, which shows a unremarkable total counts of 310 cells. Anywhere between 300 to 500 cells would be adequate to say that a good sample what we have collected actually, and predominantly neutrophils followed by lymphocytes of 10%. AFB smear and culture was negative, and the macrophages in cytology was 80%, neutrophils 5%, and predominantly macrophages with few multinucleated giant macrophages, which points out the possibility, can we get in throw in the hypersensitivity pneumonitis and also as one of the criteria when with lymphocytes less than 15%. Now, with histopathological thing, we can see this particular histopathological slide actually, which shows an exuberant of fibrosis representing normal lung parenchyma and also represented by a hypocellular fibroblastic proliferation with minimal chronic inflammation. When you go to the high power mode actually, you can see smooth muscle metaplasia of intervening fibrotic stroma with remnant alveolar spaces lined by hyperplastic type 2 pneumocytes and few other macrophages also noted in this particular high power field. Now, as a nutshell, when it comes to biopsy, the histopathological thing actually, you can see that fibrosis is extending into perivascular, peribronchial regions and no granuloma. And at the same time, at places, alveoli shows macrophage density with multinucleated Jan cells. No, it's in the alveolar place, the multinucleated Jan cells, and microscopically honeycombing remodeling is seen. So the bottom line, at the end of your biopsy, came out with the histopathological features supporting of a non-specific interstitial pneumonia with fibrotic type. Now the diagnosis tilts more in favor of a lung dominant CTD, ILD, less likely possibility of an hypersensitivity.
Nandu video barbeku andre adu start video anta click madla.
Now the plan of care actually. Now we lung dominant CTD, ILD, initial steroids was then slowly it was tapered, and patient was started on MMF as a drug of choice when it comes to lung involvement predominantly, and versus cyclophosphamide because of the reproductive age group. We didn't want to get into the fertility factor also adding a major impact. We went in for MMF, and the patient was closely monitored. This is one of the line which I want to emphasize in this whole presentation: monitoring the symptoms, imaging, PFT and echo is a key for the next patient to follow when you have this sort of a lung dominant ILD to get certification into whether there is really fit into a definitive criteria for CTD, and also vaccination as a part of it also was continued. And if you see the serial PFT, and this is a nutshell to sum it up all the changes which has happened in the last 1 year. At least every 3 to 4 months we do this sort of a PFT to closely track about what is the lung functioning capacities. At the start we have this sort of a 56% FVC, slowly and more or less in the same region. At the end of March recently we were able to get this 51%, and at the same time DLCO, which was initially 48%, slightly dropped to 41% in the December 2019. And also 6-minute walk test, not much of a changes. And in the process of following up the patient also, we were able to pick up the swelling of the digits of puffy fingers, and also the Raynaud's phenomenon was also picked up in the process of this particular follow-up, and was also treated with appropriately with the calcium channel blockers. And this is a CT scan. It is a progress report of whatever the good work is done in terms of delivering with the MMF, meticulously following it with the required PFTs, and subsequently after 1 year, this was a CT scan. What we can see, same thing with apico-basal gradient with less of a ground glassing. As you go down, you can see that more of a traction bronchitis in the basal segments actually, which is prominent actually. And this is sort of a video which will sum up the changes, what we say in terms of slightly interval progression of the traction bronchitis and the small amount of fibrosis in both the basal side of the lungs. To refresh the memory, I'll just give a thought process in terms of first CT scan. This was a CT scan which was done in the month of February last year, before we could diagnose of a lung dominant CTD ILD with predominantly ground glassing with minimal traction bronchitis in the bilateral basal segments. So after 1 year follow-up, actually, patient recently presented 4 weeks back with the left upper lobe and left lower lobe paresthesia, right side headache and blurring of vision. Initial thought process was to rule out any sort of a neurological abnormality. We had to do with an MRI to rule out any sort of a multiple sclerosis with this context, and also found to have a very low level of a B12 which was scattered, and patient got better within a couple of weeks. And to sum it up, clinically stable without significant hypoxia. PFT showed mild degeneration, and the CT scan showed a slight amount of interval progression in interstitial fibrosis with traction bronchiectasis. And to sum it up, to the recent current opinion dermatology comes with the disease progression criteria with FVC less than 70%, HRCT more than 20% increase in the involvement from the baseline, progressive decline in FVC by 5 to 10%, DLCO decline by 10 to 15% in the last 12 months of follow-up. And now we are planning to start with patient on a rituximab. And at this point of time, I would like to just sum it up, all things, whatever we have done in the last 1.5 years with this sort of ILD, what we have seen. And the thing is, what we're noting in our ILD cohort is that we are predominantly having a CTD ILD as a number one common part of ILD, what has been encountered in our Aster ILD clinic. And our cryobiopsies, 18 nearly constitute 13 to 14% of our ILD following MDD goes for cryobiopsy. And the major point which I want to take out from this presentation is biopsy change the diagnosis and treatment to the tune of 67%. And there's not much of a complications which is noted in our series, with just 2 shallow pneumothorax which is noted in the thing. I would like to end my presentation by thanking my team, which has been there throughout in terms of organizing the mental discussions and taking the ILD to the next level in our Aster group. Thank you. Now,
Thank you, Dr. Sunil.
Yes, sir.
We actually have a lot of questions. Shall we go to the questions directly? Or should we first give Dr. Vimal a chance to tell us about that CT and then go back to the panels and the audience?
Sure, sir.
So Vimal, would you?
So again, a nice CT scan, and what we can see on these images, which was very nicely pointed out, is the esophagus, which is very prominent, that's dilated, that kind of starts to raise some red flags. What we're seeing is this diffuse ground glass change, especially along the anterior aspect of the lungs bilaterally. And as we go into the next sections lower down, what becomes very clear is that there is ground glass consolidation towards the dependent aspect of the lungs with traction dilatation of bronchi. Now, these are very, very classical areas of NSIP involvement. There is no cystic change. There is no honeycombing that we are seeing. One of the other things is There is air trapping is not a predominant feature, although this is just an inspiratory scan. It may be there in the expiratory scan, but because of the pigeon exposure and a DD of chronic hypersensitivity pneumonitis, it would have been good to have a look at that also. But on imaging wise, this is a very good case of connective tissue disease related NSIP ILD for us, because we are seeing esophagus is dilated. The radiological pattern fits in very nicely with the NSIP pattern with some fibrotic change. And the follow-up CT, what we see in the end is that the ground glass has come down, but the fibrotic pattern is still there with some areas. Here again, you can see that the ground glass is relatively better apart from the anterior segments, but the lower down, the ground glass has improved, but the fibrosis is still there. So improvement of the inflammatory component, but the fibrotic component still remains in this patient.
So I'm going to go to Dr. Dharmanand at this point. Dr. Dharmanand, anything
Yes.
you'd like to mention?
Yeah, this patient, if you go back to the history, she had acid reflux symptoms.
Yes.
She had some joint pains. Some rash was mentioned in the history. So probably she had connective tissue disease slowly going in. One of the important tips I can give you is ask the patient to show her old photograph. Many times when the facial appearance changes very slowly, people don't pick it up. People think that I'm running around in the sun, I've become a little darker, maybe I'm dieting, I've become leaner. So you can see that old photograph, you can see that facial changes. That can pick up very early scleroderma. And also look at the hands, like if it is puffy, and look for any pitting. So that would pick up early scleroderma. This patient did develop puffiness in the hand and Raynaud's the subsequent time follow-up.
Subsequent visits, actually. That's right, sir.
Yeah.
No, I think this is one sort of a things actually which enumerate that actually. We want to brand this thing as a systemic sclerosis. Initially to start with, we had ILD features. We had this sort of a SL70 being a marker. These two things may not suffice to give a criteria to fit in a systemic sclerosis. We need to add, for this follow-up is a very crucial thing. I think studies again and again it's been proven beyond that actually. Initially ILD is a one, then later close follow-up, the other components also adds on to that. As of now, where we stand, we had this Raynaud phenomena adding 2 to 3 points, and with that of a puffiness of the finger, we are adding 2 points with an ILD, with the bio antibodies, which has been positive, points out to a 10 scores. Anything with the Euler criteria of 2013, we need to have anything numbers more than 9 to call it as a systemic sclerosis. And this, with the chronic follow-up within 3-4 months, we're able to achieve all these things, and we're able to give a systemic sclerosis with secondary Raynaud's phenomena as a diagnosis at the end of the whole story.
That's correct, Sunil Kumar. But one point of caution. This criteria is only for if you want to publish this patient, if you want to include this in your cohort, which you can publish. To make a clinical diagnosis, for me, it is scleroderma. Very early scleroderma, which will not fulfill the typical criteria, which is a classification criteria. So this patient had a clue. She's a interstitial lung disease, autoantibody positive. She had GERD. And that must be, if you have done an esophageal manometry, definitely would have picked up a lower esophageal sphincter dysfunction. And she had some joint pains. If you carefully looked at her skin and facial appearance, would have picked up a scleroderma. So what I'm trying to tell is what you are telling is absolutely right. But you don't need to fulfill a criteria. We can call it as a scleroderma. I would call it as a scleroderma. But if you want, you can call it as an undifferentiated connective tissue disease in the beginning. And once it fulfills the criteria, they can be labeled as. There's a little controversial classification versus diagnosis. For diagnosis, classification criteria need not be fulfilled. Most of the early rheumatoids may not fulfill the older rheumatoid arthritis criteria. So we don't go by the criteria, one. Number 2 point here is, if she has deteriorated in the 12 months after initial improvement, the compliance with mycophenolate is extremely poor, particularly in youngsters. So this point has to be, if you ask, definitely say, I'm taking sir. But if you ask clearly, they might be missing a lot of dose of mycophenolate. If a poor compliance is established, it is better to go back to mycophenolate, increase the dose up to say 3 grams per day, then consider rituximab. That's what I would suggest.
So in this particular case also, initially the patient was put on usual escalating doses actually, where in the month of December when we had a sort of small amount of dip in the DLC and also we escalated the dose to 3 grams per day actually. But in spite of one and a half year of microfluidic with small amount of symptoms slightly getting out of the way, and with this, I think probably we were asking for the patient for the rituximab in the recent stuff actually. Then
This
as a
is
part of workup of
That's perfect regarding your case, sir. I'm just telling you these points because this is extremely common in our practice to have very poor compliance with microfluidic. I want you to keep that in mind rather than jumping. For your patient, I'm sure you would have taken all the precautions. Chetana was there. I'm sure she would have taken the precautions. But I'm telling as a group, we should look at compliance. We have lost quite a few patients claiming to be taking the medicines, but if you retrospectively, all their medicines are dumped in some corner of the house.
Can I ask one question to Dr. Vimal actually?
Can I go on to the questions which our audience is asking, because they've been listening and asking? Dr. Harish from Delhi says, can somebody describe the exact definition of ground glass appearance in this case? How do you differentiate CT artifacts or movement-induced artifacts from a GGO appearance?
Dr. Sunil, can you just move to the next slide in this, please? Perfect. Okay. So ground glass, by definition, is an area of increased density, which we can see in the right top image towards the left lower lobe. How can we differentiate it from areas of movement artifacts? Classically, if you look at the lungs, you're going to get diffuse movement artifacts. It's very less likely that you will get focal areas of movement artifact and not the other parts of the lung which have moved. That's number one. Number two, what happens when there is movement artifact, the vessels become very blurry. You get kind of a step, that appearance that you can see, which is not the case here. The edges are all very clearly well defined. So by ground glass, what it means is that it's not bright enough like a consolidation that you cannot see beyond it. You can still see a little bit of lung beyond it, and this is what the ground glass would be. For movement artifact, the entire area that you're seeing will be involved, and the vessels will not be as sharp as this. You will see some blurring in there.
So I'm going to ask only two more questions because we're running very short of time. I'm going to combine two questions. One is from Dr. Damodaram, who says, when the SCL70 is positive, do you really need to do a lung biopsy? And I'll combine it with Dr. Ajay Jain, who asked the same question, just was cryobiopsy required in this patient? And Dr. Vivek Padekal asked, did this biopsy really make a difference? So Dr. Sunil, would you like to answer that? And then I'll go to Dr. Sujit and ask him what he would have done.
So basically in this particular context actually, we had this sort of an history where the exposure history is also one which one was also significant actually. At the same time, when it comes to your BAL also, BAL history, they had some alveolar macrophage giant cells also. This is also one sort of a thing actually. When it comes to biopsy of this particular cryobiopsy also showed intra-alveolar giant cells actually. That means there's a chronic aspiration component also adding on to this particular intra-alveolar macrophages. As compared to the conventional understanding, if you want to differentiate the lung dominant ILD with that of a hypersensitivity pneumonitis with negative for any sort of CT features to say the HP, where biopsy comes up very handy, being a young patient, if there's any deterioration in the future, to at least for the planning of the next level of care, we would like to go for at least tissue preserving to make sure whether which category we belong to in this particular patient.
Dr. Sujit, what is your...
just a quick comment. Probably we may not have done a biopsy, but it's very good to see the biopsy. You know, tertiary care institutes need to get more tissue to work up cases better. But I agree, if you really don't have facilities for cryo or a VATS lung biopsy, you wouldn't do it. I would probably Murli have considered an antifibrotic at this stage for the patient. I think this patient fits all the criteria for nintedanib now, that the lung function has deteriorated and the fibrosis has progressed. Is there any reason you're not considering an antifibrotic, Sunil?
So basically, in this particular patient, also I think what Mulis also mentioned actually, RP, Raynaud's phenomena is one of the contraindications to start in nintedanib. That's what actually, which points teased out in this particular case actually, sir.
Oh, okay.
A patient was stable for more than 7 years with RP negative was the patient which was picked up for nintedanib trial actually at this particular census trial.
And this is
All
probably a good time to ask Dr. Srinivas Rajgopal. Dr. Srinivas Rajgopal is messaging from Toronto. Good friend, one of the most academic pulmonologists I've seen, I've met. He asks, how do you reconcile the CT with the biopsy? The CT looks all inflammatory, the biopsy looks all fibrotic. I'm not sure whom I should ask this. Dr. Syed, would you or Dr. Lakshmi Narasimhan like to take this? How do you reconcile the CT, which looks inflammatory, with biopsy, which looks all fibrotic? Are either of them on? Or
Yes,
Dr.
sir.
Syed, are you on? Yeah, can you answer that?
I think from where the biopsy has been taken also matters, I feel. I think he has taken it for right lower lobe.
Right low posterior segment and the lateral segment which was chosen for this particular biopsy. Actually.
Yeah, I think that makes a difference, I feel. According to me, whatever giant cells also you have picked up, I think it is predominantly because of the aspiration. That's why the right lower lobe involvement is there. And there is some amount of fibrosis, if I'm not wrong. I think Dr. Vimal can comment on that. So a lot matters on from where you are taking the biopsy. Though grossly this looks like a ground glass opacity, some amount of fibrosis, subtle fibrosis must be there.
2 points. What I'd like to add is, one is this kind of discordance is well known in several studies, and secondly, that's where the MDT comes into play. When you have this kind of that's why we have these multidisciplinary teams.
So to clarify, Dr. Sunil, do you all do multiple biopsies from different lobes, or do you take them all from just one lobe, one segment?
No, so we do a multi-lobar biopsies actually. So I've taken actually nearly 4 pieces actually, 2 from the lateral and posterior, and the anterior segment also was taken in this particular patient. Actually.
And was there any difference between these biopsies? Did your pathologist?
So predominantly, I think the posterior segment had this sort of a tinge of more of a fibrotic pattern as compared to the lateral and the anterior part, which I've taken from the different lobes actually, sir. Predominantly, the inflammatory things were more in terms of anterior and the lateral segment as compared to the posterior segment actually, which is self-explanatory with that of a CT scan also. The fibrosis also more so in the posterior basal segments as compared to the lateral and anterior segments of the lower lobes.
Right, thank you. We have to stop at this point. I will request Dr. Syed to present his case. Dr. Syed is a colleague of mine, my very, very reliable colleague, one of the best pulmonary physiologists I know. And he's going to be presenting the third case from our team. Dr. Syed?
Okay, 1 second, sir. I'm just loading the thing. One second. Am I audible?
Yes, you are, clearly.
Can we see the slides? Okay, I'll be presenting almost a similar case. Basically, a 62-year-old female who came to our OPD in 2016 with history of some dry cough and running nose, predominantly airway disease symptoms. And she was basically referred by a well-known physician in Bangalore for evaluation of ILD as he found some crackles. But when we examined, the crackles was very subtle. Nothing significant crackles were there, and there was some rhonchi. She was known hypertensive and she was on beta blockers for the same. And she was also having some hypothyroidism and she was on the treatment for the same. Nothing significant clinical examination apart from rhonchi. Hence, we thought it is airway disease and we put the patient on bronchodilators. Meanwhile, she had some vision problems. She had been to an ophthalmologist. She gave a history of family history of some liver disease. Hence, she was investigated for this Wilson's disease. At that time, they have done some LFT and ANA. LFT was supposed to be normal and ANA was negative in 2016. Patient was doing well for 2 to 3 years. She came to us again in late 2018 with history of increased breathlessness, predominantly on exertional breathlessness this time. She also had some dryness of mouth, restricted mouth opening, beaking of nose, skin thickening. Basically, I'm talking about all the features of systemic sclerosis at this time. Systemic examination wise, she had this fine crepitation in posterior auscultatory areas, and X-ray at this time was suggestive of bilateral mid-zone, lower zone reticular shadows. Earlier, the X-ray was not significant. That's why we didn't bother to do anything at that time, imaging wise. At this moment, possibility of ILD was considered, and we ordered for a CT thorax, and also we involved a rheumatologist to see whether she is having any connective tissue disease. Echo was showing a PSP of around 44. She will fit into mild to moderate at this time. Ejection fraction was normal. RA-RV was also normal. PFT was around, FVC was around 65, that is mild restriction. And DLCO was around 35, though I feel she has not performed properly. She walked around 360 meters with a lower saturation of around 92% at this moment. So we took a rheumatology opinion, and she was found to have some involvement of salivary gland, and clinically she fit into this systemic sclerosis. But her ANO profile, again, which was repeated, showed only RO52 being positive. Nothing else was positive at this moment. So this is the CT scan which was done when she came to us in December 2018. You can see some kind of fibrosis, subpleural involvement, and also lower lobe fibrosis is there. I think Dr. Vimal will comment on this at the end. So this is the CT scan of the patient in December 2018. Predominantly lower lobe and mid lobe involvement. So these are the images which were taken from same video which I have shown. And this is the lower lobe cuts. So as usual, we have a very good multidisciplinary team. We involve radiologists and rheumatologists when rheumat cases are there. And the decision was possibility of CTD ILD and versus NSIP was kept in mind, but CTD ILD was rated above NSIP at this moment. So option of biopsy was given to the patient. Patient refused to get a biopsy done. So she was started on mycophenolate mofetil 2 grams per day, and she was started on steroids also in a tapering dose. And for her dryness symptoms, we had given this pilocarpine. Symptoms improved. Review CT was done again in March 2019. That's around 4 or 5 months later. And this was a CT scan which was done in March 2019. So again, we reviewed this case in MDT. So what it was said was like there was some decrease in the acute component, the ground glass, whatever was there, it had decreased, but the fibrosis was worsening at this time, though clinically she was improving. These are the images again. So this was a CT scan at that time. Now again, she followed up in late 2019. She was doing much better. Repeat PFT, DLCO was done. Almost same. There was no much change in PFT and DLCO. FVC was almost same. She walked around 330 meters. Earlier, she had walked around 360 meters with no significant desaturation at this time. Now, this was a repeat CT scan again in December 2019. So grossly, if you can see that there is no much change, the fibrosis also almost remains same. Probably some acute component has gone down at this moment. And I don't think there is any esophageal dilatation at this moment. And these were the CT pictures. So she's doing fine actually, and she's currently on this MMF. Steroids have been tapered. I think she's on around 2.5 milligrams of prednisolone, and she's doing much better. We have the photographs, in fact, where and she's doing well. Now, the whole idea of presenting this case was initially when she presented to us, she presented as airway disease. Was CT scan needed at that time itself? So did we miss doing a CT scan, anything? The other thing, how does it make a difference if you pick up this IPAF or CT-ILD cases much earlier? These are the things which probably I would like to address to the panel. And the other important thing is we offered the patient a biopsy. Is it important to get a biopsy when you have a specific pattern? So at this moment, I would like to share our experience, what we have done and what our data says. So if we go back in 2012, that is when the guidelines had come, we had discussed around 75 cases in our MDT, and 320 cases of ILDs have been discussed after 2016 till December 2019. So if you see the difference, you can see before 2012, UIP patterns, whatever MDT, I'm talking only about MDT, no biopsies at this moment. So we had seen out of 75 total cases, 39 were UIP pattern. That accounts for around 52% of our diagnosis. CTD-ILD was around 12, that accounts around 16%. Sarcoidosis remained same, 16%. NSIP was only around 4%. And hypersensitive pneumonitis was around 6.6%. This is way back in 2012. When we see the data in 2016 onwards, we have seen around 320 cases, and out of that 70 have been diagnosed as UIP, that is around 21%. There's a drastic fall in our diagnosis of UIP. CTD-ILD and sarcoidosis, if you can see this, they remain same. The percentage almost remains same, around 14.3%, and CTD-ILD around 18 to 19%. Whereas NSIP has increased. We are becoming more non-specific nowadays, I feel. And hypersensitive pneumonitis also has jumped to almost double, around 13.12%. So this is how I feel. And of course, the CPFE entity was not there, though we have found 1 or 2 cases of COPD with ILD in this before 2012. And we have diagnosed more and more of COP after 2016. So definitely the guidelines has changed our approach, our diagnosis have changed. Every second patient which was diagnosed as UIP, now I think every 4th patient has been diagnosed as UIP, and we are diagnosing more and more of NSIPs nowadays and HPs nowadays. And we are fairly clear long back ago also about sarcoidosis and CTD-ILD. So other thing, what I wanted to see in our data is, what is the role of this biopsy? Should we get all of them biopsied? So if you see this data after 2016, I think we started doing our cryobiopsies only in 2015 onwards. So you can see the data. We could do only about 9 biopsies out of 42. 42 cases were MDT diagnosed as HP, and in that we could convince only 9 people for a biopsy. And out of them, 7 people had a confirmed diagnosis of HP. That is, the concordance rate was around 77%. CTD-ILD, you can see here almost 85% concordance for this. And NSIP, you can see is almost half of the time we were wrong when we did a biopsy in these patients. Of course, sarcoidosis, we have done a lot of EBUS TBNA also along with that. You can see the concordance rate around 86.9% of concordance. And if you see overall, out of 188 patients we have discussed, this is barring UIP I'm taking because we don't do biopsies for UIP. Out of 188 patients, we did around 74 biopsies, and concordance was in around 60%. So fairly a good number, 81% of concordance. Though I feel like, this is not a kappa value what we have calculated. So again, I've taken NSIP out, means IIP pattern is out. When you see non-IIP pattern, your concordance rate is around 85%. So out of 148 we have discussed, 62 biopsies were done and concordance rate was around 53, 85.48% times we were right in our MDT diagnosis. That's what I can tell you at this. Though the sample size is less, whatever biopsies we have done is much lesser. So I still feel MDT has a major role to play in our setting. Though we are a tertiary care center, we have all the facilities. I think we should be wise enough to consider biopsies in specific cases. And most of the time, 85% of the time, as I said earlier, you might be correct if you are dealing with non-IIPs. And if you are dealing with a NSIP pattern, I think that's the time your biopsy comes into picture. So I'd like the panel to have take the questions what I had.
Dr. Sunil, Dr. Syed, we'll have to start Dr. Sujit Rajan's talk. He's got another meeting at 9. So we'll go straight on to his talk and then we'll come back and have a panel discussion, which includes questions on the case you presented. So can I request Dr. Sujit Rajan to start immediately, please?
Thank you.
Our apologies, we're running late.
No problem. I will just share screen. Can you see the slide that I have? Yes, sir. You're clear? Okay, great. Can you hear me clearly also, Murli?
Yes.
Thanks, Syed, for a fascinating case again, and all these cases have been really great. I will try and finish my talk in 10 or 15 minutes so that we can have time for questions. Basically, ILD management in the COVID pandemic, I think all of us interested in ILD here have been concerned about our patients who are going to probably deteriorate. We have warned some of them. We have tried to do everything possible. But I thought there are some learnings that we have had while this lockdown has occurred. We know that ILD is the 40th leading cause of death worldwide, but has gone up by 85% in the last 10 years. And that is how important ILD is. And that's why many respiratory physicians realize also that a lot of the referrals that they get from general physicians are less and less airway disease, which is pretty straightforward in many cases to be treated by a general physician, but more of diffuse lung disease. And so we had the registry, and you can see here clearly that 47% was HP, though from the cases I saw largely coming in from the southern part of India, and from what data I've seen from Kerala, CTD-ILD seems to be the predominant ILD in the south of India. HP more as you move north, and definitely in Mumbai. If you look at our CT radiology data, HP, chronic HP really predominates. So putting that in perspective, we also have this fact that only 7% of the patients in the Indian ILD registry had a lung biopsy. And so most of our HP patients actually are diagnosed without a lung biopsy. And that's something that we need to remember. And Syed very elegantly showed that how his MDT was useful in the absence of lung tissue. And we will have to, I think, look at that. I know we saw some great cases with cryo, and I would love to have someone, we have people who are doing cryo in Mumbai, but we would want more people or people doing it much more often than it's currently done. And I can understand that the current COVID pandemic is going to be a deterrent to getting invasive procedures done in a hurry at least. So I don't see them happening too much in the next 2-3 months at least. And maybe even less often this year unless we have good MDDs and the patient is also reasonably convinced to stay in the hospital a little longer for that. There's also the risk involved of contracting some infection in a hospital when many hospitals now have their COVID designated beds. And a lot of our ILD patients, as we know, are elderly patients. And so the other concern is of elderly patients being subjected to invasive procedures in a hurry at least. So of course, with good conversations and communication, one can manage a lot of these things, but I think we're going to see a little less of it. Therefore, I think it's an opportunity to improve CT radiology. So I think that's, and Vimal is here, and I think I've been speaking to my CT colleagues. A lot of things are going to happen here, and of which I've listed 3 of them. One is data transfer, and I think this is something in hospitals which don't work with a PAC system. I think many of us have the luxury of a PAC system in our hospitals, but I can tell you the majority of hospitals in India do not. And therefore, transferring data, and if Aster has set up an ILD center, which I'm delighted to know, and I met Srivats also at a meeting recently, and there are other centers now with ILD clinics. We are going to need data transfer. If someone from another city is not going to take a flight in a hurry today, we will need PACS or Stratus or platforms where the imaging can come straight to my laptop or to my hospital, so that at least is there. Because once you have the history and the imaging, the only thing left is clinical examination, which a few things you can do on a screen, maybe look for pedal edema, Raynaud's, but there's not, I think clinical examination, the local respiratory or the primary respiratory physician will be responsible for. You can also get coronal and sagittal images, and now through artificial intelligence, we can get CT fibrosis scoring. So I think in the COVID pandemic, this is a time to actually introspect and reflect on how we've been looking at scans. You'd be surprised, even today in India, there are many respiratory physicians who look at film. And this is, I think, a time period where we should reflect on that and probably change towards only looking at soft copy and probably try and make film obsolete as far as possible. Few words on the pandemic and lung function. Our lung function lab is closed, of course, right now. There's probably one test being done. Our technicians dutifully are coming, but I wish they were designated to other areas of the hospital, which need them much more than the lung function lab. Monitoring, we know, is required. Prognostication, we know the gap index, and that's where we need to work towards. But having said that, I see now in lung functions, we're going to see them being done less frequently. And I'm projecting this for the next 1 year at least. I don't see people wanting to go to different parts of the hospital too much, especially areas where they need to blow out. And so you're going to have our PFT techs also worried who's going to come in there coughing. So there's going to be a paradigm shift, I think, in how we schedule our lung functioning. I would probably get a vital capacity done every 3 to 4 months in our patients in the first 1 year. I'd probably come down now to 6 to 12 months. And portable spirometry, I think, is going to play a big role. And we're going to see more machines in this space. And I think we're going to be in a situation where we're going to actually tell our patients to keep a portable spirometer and monitor their FVCs, just like we give peak flow meters to our asthmatics. The costs are coming down. And I do see Indian companies looking at manufacturing these machines also. There's research also on portable and smaller DLCO machines. And if that hits the market, I think we're in for a sea change in monitoring. Treatment, well, just broadly, this slide tells us about how to choose our antifibrotic. And I think that's not rocket science for many of our respiratory physicians here, but that's not my talk on how to choose an antifibrotic. You can choose pirfenidone or nintedanib. And we also learned that in Raynaud's phenomenon, which I also learned, nintedanib is not ideally to be given. But having said that, in progressive fibrosing ILD, both these drugs are going to have great emerging roles. So we're going to see not just IPF, but a lot of other progressive fibrosing ILDs that will also need these two drugs. And we know, as Murli elegantly showed in his first talk, that you can either focus on slowing disease progression in IPF, which is pirfenidone and nintedanib, maybe consider a long-term antibiotic when the cleanup IPF trial results are in. PPIs and NAC monotherapy, still controversial in slowing progression, but in patients with a strong reflux component or where you have the TOLIP gene mutation as a possibility, then you could probably use PPIs, a NAC monotherapy. When it comes to treating symptoms, of course, we are focused on oxygen, rehab, and palliative care. None of these can be understated, actually. They are so important because oxygen is a drug that is increasingly required, especially, and I think those are people who should be exempt during the lockdown when patients need oxygen. The concentrator distributors need to be given access to move to patients' home. Rehab on teleconferencing is going to be very important, and palliative care. A few points in the pandemic is that we use immunosuppressants and we use antifibrotics. So we have this whole list of immunosuppressants and antifibrotics, but a few words of caution here. If you're on an antifibrotic, you're not really at a greater risk of COVID pneumonia unless you're an elderly patient. I would keep the antifibrotic on. So for all our patients who are on an antifibrotic, please don't stop them. I would encourage phone, email, and Skype consults for all these patients during the lockdown period for sure, and probably a little longer, especially if they're elderly. I would encourage their medication to be collected by a family member. And these patients coming to pharmacies is obviously at risk. If they have a family member who can collect it, a stockist, we are trying to be helped by pharmaceutical companies to ensure that. And lung functions really only if it's urgent. I don't think there's anyone who needs an urgent lung function during the pandemic. And so that's something we're definitely not doing. Also, if it's a new pulmonary fibrosis, work on a working diagnosis like the Fleischner Society has recommended. And I think that is pretty good. You don't need a confirmed diagnosis. Use MDD and Zoom like we're using today for atypical cases. It's such a wonderful medium to discuss with your colleagues more atypical cases to firm up your diagnosis. And if if the patient has had a lung function done in the last 6 months, you're good to go with that. And start antifibrotic drugs unless there is a contraindication. Immunosuppressants, some broad issues for all the audience. Stay on them unless there's signs of infection. Now you have some patients with CTD, ILD, chronic HP who frequently get infections, UTIs, lung infections. We know those patients. Those are the patients I would call up and tell them, come lower on the dose if possible, keep on the lowest dose or even omit the drug during the lockdown period and for a little longer. The risk of COVID pneumonia would be much higher here in a frequent infection phenotype of interstitial lung disease on an immunosuppressant. There's also talk of lymphopenia in sarcoid, because we know sarcoid patients have low lymphocyte counts, but that does not increase their risk for COVID pneumonia, even though their lymphocyte counts are low. There's been no increased risk seen across the world right now in initial experiences. Of course, there's no data that I have to show you all. What about CHP and RA-ILD? Two diseases I see a lot of. I see about 6 to 7 patients of ILD in a day. The majority are CHP. We know there's weak evidence of immunosuppression in CHP. So delay in starting mycophenolate azathioprine if you haven't started it already. Oral prednisolone 20 mg or lower should be fine. Avoid very high doses of steroid. And I would say if you had to start MMF or methotrexate, when I'm saying start, not continue, I would wait till the pandemic is over and the patient is reasonably stable before you put them on that drug. Rapidly progressive ILDs like vasculitis, CTD ILD, where you see the patient progressing rapidly, I would prefer an IV cyclophosphamide pulse, probably with an antibiotic cover, prophylactic, over rituximab. I mean, we were just discussing that, and I think rituximab's half-life is just too long to really recommend it long-term. In this the next few months, I would prefer to go along with IV cyclo. There is data on post-COVID lung fibrosis. We don't know. There's no great study that's come out on this, but these could be patients who have pre-existing fibrosis, which we never knew of before, or a genetic susceptibility. But all in all, it looks like the antifibrotic should continue. The immunosuppressant, you need to be a little careful, try and come to the lowest dose. There are recommendations by the NHS, the last couple of slides really, on who are higher risk. And we know that these groups, the 70 plus, in fact, Sweden, which is one of the countries that doesn't have a lockdown, because 50% of their workforce works from home, have just advised their 70-year-old plus to stay at home. I don't know if that's a wise decision. We'll know in a month's time whether that decision was wise. Pregnant women, airway disease, heart disease, and all these neurological and uncontrolled diabetic patients are high risk. CDC recommendations for ILD patients are also out on the net for those of you who want to read them. But I would recommend all of you who have websites or who communicate on email to tell your patients to go to the website of the CDC on this. Don't shop frequently. These ILD patients should be told to use hand sanitizers, frequent washing, be active at home, exercise at home, avoid air travel, crowded areas, and keep adequate medicine supply. Many of them have forgotten to get their meds, and half of our patients are calling us up for medication that they can't get. Keep a 6 feet distance from others who are sick. Avoid touching eyes, nose, and mouth. I know these sound repetitive. We've heard it all over the last 3 weeks, but it makes sense to keep repeating it to our patients. And clean and disinfect frequently touch objects. Face masks, especially if the patient has influenza-like symptoms, I would definitely tell them to wear face masks, and sometimes even call them to your clinic from the car and tell your secretary to call them a minute or 2 minutes before you're going to see them. That would also help reduce the infection. Communicate well. I can't tell you how important it is. Palliative care is so important. Unfortunately, we don't have enough of them in India. And for the elderly ILD patients coming in with COVID pneumonia, we know we are unlikely to be able to cure many of them. So at least we can care for them well, talk to their relatives, get them to talk to their relatives through iPads, which they're doing in New York. We haven't fortunately seen that surge of critically ill patients in India as yet. But if that happens, we will realize how important palliative care is. Panic is huge in the public, and I cannot tell you how much public panic harms a vulnerable community. People are so scared about many things, and it's our responsibility to reduce that panic and tell patients that more than 80% of patients with COVID infection have no symptoms or very minimal symptoms, not even requiring treatment. So I think it's our duty to reduce this panic. Watching the news every day can just escalate that to unimaginable levels. These are the triggers for advanced care planning. I won't go into that. Just to conclude, ILD patients are a vulnerable population. CT data transfer is going to become very key in managing them better in the long term. Portable spirometers are going to be here to stay. This is my thought. We got to be careful with immunosuppressants, but continue antifibrotics in the patients who are on them. And let's communicate very clearly and reassuringly to our patients. Thank you very much, Murli, for allowing me to proceed the discussion on the last case. Thank you.
Let me unmute. Yeah, thank you, Sujit, for that excellent talk. And I'm sorry we pushed you right to the end.
No problem.
You speak about communicating clearly. I think we can't get better communication than you just gave us. More clear communication than you just gave us, and some very valuable messages there. We let you go away if it's time, but I request the others to stay on.
2-3 minutes. I have 2-3 minutes. No worries.
2-3 minutes. Okay, wonderful. So what I'd like to do is go on to the questions at this point. Can I ask our admin team if there's anybody else who's joined us? Dr. Satish was supposed to join us, and Dr. Ravindra Mehta, are they with us? Okay. Right.
No, I'm here. I'm watching.
Sorry, who?
Yes, I'm very much here. Watching from 7 o'clock. Don't worry.
Right. So welcome, Dr. K. Satish. Satish is an old friend of mine. I mean, he's not old. He's eternally young. But we've been together a very long time. And Satish, of course, is the president of our Karnataka Pulmonologists Association, one of our best-known pulmonologists and one of our best pulmonologists, extremely experienced, and, a person whom everybody looks up to, not just for his pulmonology, but for his persona also. So, Satish, I hope you're going to be here with us for some time. Hello? Satish, are you still here? Network is going. Okay. Let me get to the questions, and will our organizers please tell us when how do I get to the questions that were being asked? Yeah, I've got them, yeah. Okay, so quite a few questions here. Dr. Srinivas Rajgopal and again Dr. Dharmanand wants to know, is active Raynaud's a contraindication for nintedanib? Census trial wanted to enroll patients less than 7 years from onset. There is nothing about active Raynaud's in the exclusion criteria. And others too have asked the same question. Can I request any of our panelists? That obviously should go straight to Dr. Dharmanand.
I'm not aware of any contraindication. I have to admit that I have not gone through the nitty-gritty of the inclusion criteria, but I've never thought that NRC is a contraindication. But
okay, I think there was some misinterpretation there of some of our previous discussion. But Dr. Srinivas Rajgopalan asked that question. He's also commented that you made some fantastic points. More questions here. According to the American College of Radiology, you have to use a dose of prednisone, less than 10 milligrams in the COVID area. But here, Dr. Sujit, you recommended you can go up to 20. Could you comment, please, if you're still here with us?
Very much, Murli. I think you can go up to 20 if you need 20. I agree you should be at the lowest possible dose, Murli. And if you're at 10 or 5 or 0, you're better off. But I would definitely not go to doses over 30 milligrams a day unless it's really required. I mean, just to give you an example, if an acute asthma attack were there in our practice, we would give 30, 40 mg of prednisolone, even though the COVID pandemic is on. But we're talking of long-term dosing here, which you would like to keep below 20. I think it's very subjective, 20, 15, 10, the lower the better. I put it at that.
Right. Before you have to go away, there's another question. Would prophylaxis with Septran be sensible in this COVID pandemic?
I think so. Especially if you're going to give pulses of cyclophosphamide, I would do that. And especially if you're on regular prednisolone, I would give it 3 times a week, 1 double-strength tablet.
So that's, I think, what we do, irrespective of whether the COVID pandemic is on or not, isn't it? Several other questions. How justifiable is it? Again, Dr. Singha from Big Boy in Assam. And again, I think this goes to Dr. Dharmanand. How justifiable is it to do an ANA profile in spite of the ANA-IF being negative? And why ANA is not done by the IF technique very often?
The preferred method for ANA testing is by immunofluorescence. This patient had an ANA, with a patient presented by Dr. Tausid, had an ANA done by ELISA. There's a chance that the ELISA could have missed some of the positivity. If you had come positive, probably I'm sure you would have taken a little more interest in evaluating the patient in 2 to 3 years before her current presentation. And
so, so that was actually done outside.
Yeah,
I mean, this is actually my patient. I'm the one who missed that initial diagnosis, if I missed it, because she had a very good response, 2 years, no symptoms.
Yes.
So I think we'll go back to that question. Sujit, do you think that it was not justified to not do a CT in that case? Or do you think we should do CTs more often whenever a person has been referred with a diagnosis of possible ILD? Because this is a very good physician who asked me this question. Is this ILD? What should I do?
Which case are we talking about, Murli?
The one that that Syed presented, Sujit?
Yes, of course. I think you needed a CT there. I would definitely have done one. Why would you not do one? I'm not clear.
My diagnosis was obstructive airways disease. This was in 2016. She had absolutely no findings.
Right.
When she walked into my clinic 2 years later, as she walked in, I didn't recognize her in the beginning, and I said, "Oh, this is a systemic sclerosis." It was very obvious. But I'm sure I didn't miss systemic sclerosis the first time, unless it was very subtle. And she did not have lung function changes, which we did. She had normal spirometry. She had a normal walk test. I often make patients walk around the clinic. I don't do a formal 6-minute walk. And if they don't desaturate, I'm usually quite happy. And as I said, she did respond to bronchodilators and inhaled steroids for 2 years.
Sure. But she did have a low DLCO, didn't she, Murli?
No, that was later in 18.
That was in the 18, right.
March 2019.
In fact, I didn't even do her DLCO. I just did spirometry for her in a 6-minute.
Sure. See, our threshold to do a scan actually these days, Murli, has come down. For reasons that X-ray is so insensitive in diffuse lung disease. Having said that, yes, if you don't need a scan, you wouldn't do it. And the patient was asymptomatic and better with inhaled steroids and bronchodilators, you wouldn't do it. If you had a suspicion for anything else, I would do it sooner these days than later. For the simple reason that 1 minute high-resolution scan is hardly any exposure to radiation, and you get so much more information. But having said that, yes, airflow obstruction, I didn't pay much attention to Syed's case. I must apologize to Syed, actually, because I was just getting my slides sorted for my talk that time. But I get your point. If the X-ray looked normal, clinically improving with inhalers, I would wait on the scan.
So this is an interesting question. Dr. Sanjeev Kumar Chugh says we are labeling the disease as ILD. Simultaneously, we're giving an antifibrotic agent that's treatment of IPF. There can be legal issues. So would any of the pulmonologists, we'll bring Satish in on this. Satish, you would like to comment on this? Satish?
Yeah, go on. Please.
So the question was, we are labeling a disease as ILD, but simultaneously we are giving an antifibrotic agent that is IPF. So I assume he means a non-IPF ILD. There can be legal issues. Is it justified to use a non-IPF ILD? Is it justified to treat with an antifibrotic agent?
Okay. So I think we have all used this kind of treatment when we didn't have an answer or response to the treatment in the beginning. For many patients with ILD, not responding, and with the data coming up in especially in terms of nintedanib in fibrosing ILD and NSIPs, I think one can substantiate saying that antifibrotics can be used in these situations, but one has to really rule out whether it is an IPF related ILD or it is a non-IPF related ILD. That's what I would do, Murli.
And Dr. Preetham, I think it's Dr. Preetham Acharya from Bangalore. He has an extension to this. He basically says our antifibrotics are approved for any other progressive fibrosing ILDs other than IPF. Are they approved? Are they FDA approved? Are they approved in India?
Yes, Murli. I think, of late in the last few months, we have had some approval from FDA, especially for nintedanib in non-IPF related ILDs. So they are approved to be definitely used in patients with non-IPF ILDs. And, you also showed in your slide and your talk on especially fibrosing alveolitis, your use of antifibrotics, especially in nintedanib. I think one is justified now to use in non-IPF ILDs, the antifibrotic, especially in nintedanib. The FDA has approved it, and then many of us have started using it, especially in CTD-related ILDs.
Question for both Dr. Syed and Dr. Lakshmi from Dr. Srinivas Rajgopalan again. He says there are 2 centers listing in TN with more than 100 transplants. Dr. Srinivas, I think it's actually 3 centers. And will you consider referral for case 1, that's Dr. Lakshmi Narayan's case, at the initial visit itself? Do you think you can refer for transplant listing? Dr. Lakshmi Narayan, and then Dr. Syed can come in also because he's our transplant specialist.
Yes, I would probably refer her, but listing is different. Because without looking at response for treatment, if you just list her in the transplant list, then taking her off, that would be difficult. But yes, probably I would consider a referral. And that point was discussed with the patient, but for various reasons, they were just not willing to go for transplant. So they were not referred. But yes, not probably listed, but yes, referred. We would need to monitor her over a period of time before we strongly consider transplant.
Dr. Syed, anything to add to that?
I agree with Dr. Lakshmi. I think we need to keep in touch with her, definitely evaluate for transplant. I think if I'm not wrong, her drop in FVC is quite significant over a period of time. I think it has dropped at least by 10%, if I'm not wrong. And we have to keep things ready. We have to talk to her that, this is the probably ultimate option as a lung transplant. So keep her informed. Meanwhile, you investigate her, whatever necessary investigations are required, and keep her ready for transplant. Though we may not list at this moment. And of course, rehab. She needs to go through all this rehab. Then probably finally, if she worsens further, we can list her.
So I think it's important to make it clear that Referral and listing are two separate things. And practically every patient who has a progressive fibrosing condition, IPF or not, we should start thinking of lung transplant being needed at some time. So I think it's good to start early, because to change a patient's mind sometimes takes time, and we're sometimes not left with enough time to do things that are necessary before moving into transplant. Going to some of the other questions, a lot of questions here. I'm going to skip a lot of these because we're running short of time. But gentlemen, any of you needs to come in on any question, please do, even if I don't specifically invite you to answer the questions.
Murali, can I come in?
Yes, please.
Yeah, quickly, commenting on Sujit's talk.
Yeah.
One of my patients just before the lockdown,
Satish,
she goes for a checkup to Mumbai. Yeah, can you hear me?
Yeah, clear now. Yes, clear.
Yeah.
Hello. Satish, we seem to have lost you. Your network is fluctuating apparently, Satish. We're losing you. Let's try and re-establish and then call you back. Will you?
Yes, I'm still. And patients are very well informed these days about.
Satish, can you put off your video and speak? Yeah. This is to Dr. Dharmanand. Yes. Dr. Dharmanand, what is the role of leflunomide and azathioprine in the first case? Would you have chosen leflunomide and azathioprine?
Leflunomide, probably no, because we are not diagnosing any rheumatoid arthritis here. Azathioprine is an alternative to mycophenolate, definitely yes. It's a poor man's mycophenolate now. And earlier, some time back, it was the drug of first choice, post-cyclophosphamide.
Do you have an experience of where some patients don't respond to one of these drugs and respond to the other?
Yes, definitely yes.
And definitely, how do you decide which is the first drug you want to try?
Choosing the first drug is always difficult. It's more by instinct. Even in an ILD, we choose cyclophosphamide or mycophenolate. Depending upon the age, comorbidities, and other factors, we choose one of them. And if they don't respond to the first one, at the end of some time, maybe 2 to 3, 4 months, we decide that it's not improving at all. Then switch over to the other medicines. On maintenance, the current drug of choice is mycophenolate. Mycophenolate induction and mycophenolate maintenance has become the standard now for most of us. But we have a choice of switching over to azathioprine sometimes as a maintenance drug.
Vimal, you're still around? Dr. Vimal?
Yep, I'm here.
Vimal, the question for you. The question is from Dr. Soumya Jain of Saharanpur. Does UIP prefer upper zones than NSIP? I think, that's my mistake. Does UIP prefer lower zones than NSIP? But you can also add about upper zones in case that was the question.
Okay, so UIP traditional pattern is subpleural disease, and there is an apicobasal gradient, which basically means that the disease is much more towards the lung basis. NSIP also tends to be lower zones, but it is much more central rather than peripheral. Chronic hypersensitivity pneumonitis can have an upper lobe predominance, and infective cases like TB and granulomatous pathology like sarcoid can have upper zone. If you're seeing a lot of cysts with nothing involving in the lower zones, upper lobe involvement, also think about rheumatoid. Rheumatoid can sometimes give you a cystic changes in the upper lobes as one part of the involvement. But otherwise, UIP, NSIP classically is in the lower zones and not in the upper zones.
And you always teach us that peripheral predominance is UIP, whereas spreading from the center to the periphery is NSIP.
That's correct. So subpleural sparing is classically described in NSIP. So if the disease is more towards the hila or center of the lungs, then we should think in terms of NSIP rather than UIP.
So there's a question again asking us, do all our patients with ILD go to an MDD at Narayan Hridayalaya? And I'll ask Syed to answer that question. Syed?
Yes, almost all the cases we discuss in MDT, I think every week we are having MDTs, and we have review cases also. I think you can see this. Most of the cases, whatever we see, unless some genuine reasons are there, we don't discuss. Other most of them go through the MDT, and it is very important. A lot of changes happen at MDT. That's what we have seen. Valuable discussion happens. I think I remember our discussions go on for 1.5 hours, 2 hours for around 5-6 patients. That's how it is.
Can go up to 10 patients also sometimes. Yeah. The other reason why I think it's useful to take it to our MDT is quite recently I had a patient, classic patient with IPF. He's on pirfenidone, doing well, and I'd completely missed a lung nodule in the lung, which he got it done somewhere else in a different city and came with the CD. A point that I think Sujit made very clearly, we must look at the soft copy. So the radiologist outside had missed it. Our team picked it up. We did a biopsy. He has a carcinoma lung. I think this was a squamous cell carcinoma, if I remember right. So that would have been missed completely until it was too late to do anything. So this is another reason why I think it's a good idea to show every case to the MDT, and they pick up subtler findings that have been missed outside and subtler findings that we as pulmonologists sometimes miss. I think it's been a huge learning experience, and we try to take every possible case to the MDT.
Can I just come in and try and answer a couple of questions, just highlight the questions here?
Yes, please.
One of the questions which was asked is there any role of CT-guided biopsy in interstitial lung disease when transbronchial route facility not available by Dr. Singha from Assam? This is something we have always contemplated and discussed in detail about, especially if you're looking at organizing pneumonia presenting as a nodule. Perhaps is the only condition where we would suggest that yes, CT biopsy may give you some results. When you're looking at a NSIP pattern of interstitial lung disease, the tissue that we get is very, very minimal, and it will not give a satisfactory answer on a CT-guided biopsy. We found some cases whereby we've done a PET and there's been some area of inflammation and there's no other way of doing a biopsy to take something, but often that has not been very contributory in the end. Infections, yes, but ILD per se, not a great idea.
Right. Any more questions that you had to ask to you and that you wanted to answer, Vima?
There was one question which actually came out, very nice question in the initial presentation, which we said, do we have any HRCT criteria for a significant ILD in an asymptomatic patient, and how to define progression of ILD on HRCT by Dr. Sunita from Hyderabad. There is a lot of interest now on fibrosis scoring, and there is a lot of artificial intelligence softwares which are available, which are able to quantify the degree of interstitial lung disease and even assess for the progression of the interstitial lung disease. One such company which is available and not much accessible to all of us right now because of the costs is also giving very good predictive results when it comes to connective tissue disease and IPF. So I think in the near future, there is an Indian company working with our group, which is also working towards getting a quantitative fibrosis assessment, and that will become more universal. And I think that will help, apart from the standard PFT parameters that you have, there will be CT parameters which will tell us what is the progression of disease and what is the severity of disease.
So we're running out of time. In fact, we've overshot by almost 20 minutes. I'm going to stop with one question, which I think all panelists can answer. is the nomenclature lung dominant CTD accepted by consensus? This comes from Dr. Manisha Daure, a colleague of ours, a person I often go to for my rheumatological problems. So we'll start with Dharmanand, obviously. Is lung dominant CTD accepted?
It's depending upon the times. Every now and then the nomenclature changes. IPAF is literally the hot favorite now. So, but what I want to take home from this meeting is, as a rheumatologist, we should be looking into the lungs so that we can pick up ILDs earlier. And pulmonologist has to look at, learn a little bit about connective tissue disease symptoms, how to pick up connective tissues early. Few simple tips could be looking at the face, old photograph or new photograph, as I told you. Nail fold capillaroscopy is one useful stuff to pick up early connective tissue disease. And of course, a quick screen of connective tissue disease symptoms like joint pains, Raynaud's, etc. And another one is many of the NSAP which you are bracketing into NSAP group. Those who respond to steroids may have connective tissue disease as the first manifestation, ILD as the first manifestation of CTD. Probably we have to be a little more aggressive. Even in Sayed's patient, ANA was positive, Rho52 was positive, but the patient has scleroderma-like features. Probably these are the patients we should do an scleroderma autoantibody profile. RNA polymerase, TLTO, U11, 12. There are few autoantibodies which can cause ILDs. And many of the dermatomyositis-related autoantibodies can have ILD as the first and dominant symptoms. So this is probably they will never reach us. They will reach a pulmonologist. They should be able to have a low threshold to do autoantibody profile. Even if ANA profile is normal, you may have to do sometimes myositis profile and a scleroderma profile. They are very expensive, cost 5 to 7, 8,000 rupees. But sometimes the money is not an issue. We should be doing.
Thank you. Any of the others wants to add to that? How often do we? I think it's part of the routine, Dr. Sunil. I think it's in your panel also that every patient with ILD has a screening for connective tissue disorder. Do you also send them to the rheumatologist whether they have rheumatological features or not? Dr. Sunil, is he around? Okay, I think he's probably left. He probably had some.
Rheumatology referral would be in place because we can look for other. We are trained to look at the other, picking up the other organ involvement, assess the overall disease activity. And probably we may have a little more experience in dealing with some of the drugs.
Right. I think since we are so badly over time, there are a lot of excellent questions that have come in. I am going to stop at this point. Thank all the panelists. Dr. Dharmanand, Dr. Sujit Rajan, though he's not with us, Dr. Syed, Dr. Lakshmi Narayan, Dr. Satish, who very kindly has joined us. Anybody I've left out, please excuse me. And most importantly, this large audience that we've had, I don't know how many we've had, but looking at the questions, they've come from all over the country, and there have been some truly excellent questions here. I hope we've been able to satisfy you with some of the answers, and looking forward to the next time we can all meet. Thank you, gentlemen, and thank you to the organizers, the Life Foundation, which specifically looks at interstitial lung disease, IPF in particular, for helping us put together this program along with Boehringer Ingelheim. Thank you all.
Bye-bye. Good night.
Thank you. Bye-bye.
Good night.